So good evening, everyone. Welcome to day 2 of our conference on cytokine release syndrome in children. I welcome all the panelists and the chairpersons who have joined us today. Yesterday, we had an overwhelming response and around 450 people actually joined in for yesterday's session. And we had a great discussion yesterday, and we look forward to a similar session today as well. With this, I'll just go through our housekeeping rules. Please keep yourselves on mute throughout the conference. Apart from the speakers, please do ensure that you're on mute to avoid any crosstalk. And we will be taking questions at the end of every lecture. And please post your questions in the Q&A box and not in the chat box. In the interest of time, we will be limiting discussions to not more than 5 minutes after every lecture. But please do post your questions, and we'll request the panelists to take questions and answer them in the chat box if possible. With this, I invite our chairpersons for the first session. So Dr. Farhan, who's the head of Pediatric Intensive Care Services at Rainbow Children's Hospital, Hyderabad. Welcome, sir. And Dr. Anand Rao, who's a pediatric rheumatologist at Manipal Hospitals and Indira Gandhi Institute of Child Health in Bangalore. Welcome you, sir, and over to you for the first session.
Dr. Farhan. Thank you very much, Dr. Chandrika. So I welcome all the delegates and the speakers for this session on the diagnostics in cytokine release syndrome. And the first speaker for the talk today on criteria for early identification of cytokine release syndrome, do's and don'ts, is Dr. Fabrizio Benedetti. And it's my honor and privilege to introduce Dr. Fabrizio Benedetti. He's a physician scientist. He received his MD, PhD from University of Pavia, where he trained as pediatric rheumatologist. After spending 2 years in United States at the NIH, he worked at the Pavia at the Department of Pediatrics. And since the end of 2003, he's at the Bambino Gesù Children's Hospital in Rome, where he serves as head of the Division of Pediatric Rheumatology and the head of Laboratory of Immunorheumatology. His research is focused on the pathogenesis of pediatric rheumatic diseases with a focus on inflammatory cytokines. His research has led to identification of numerous biomarkers for disease activity and prognosis and therapeutic targets. These targets were brought to the clinic as Dr. Benedetti designed and led as international lead principal investigator many pivotal registered clinical trials. He has been or is presently leader of 11 phase 2 and phase 3 trials in pediatric rheumatic diseases. So it's our honor and privilege to welcome sir, and I welcome him and request him to start his talk now.
I couldn't unmute myself. Apologies. I was trying to find the button. Well, thank you very much for your very nice introduction. This is what I do in life. I'm a physician scientist, exactly as you mentioned it, and what I do is try to search for biomarker and novel targets. This is what we do in our department. However, this is a very clinical, fascinating title. Criteria for early identifications. Let me get to screen mode so that you can see it. Let me invert. You should see it properly now. I hope this is the case. Give me a thumb up if everything is.
Yes,
everything is okay.
You can see it clearly.
Thank you very much. So when we talk about cytokine release syndrome, or whatever we want to call it, and we'll get to that in a minute, we actually should go back to the definition of horror autotoxicus that was defined by Paul Ehrlich in the early years of the last century, in which he alluded to the fact that the immune system is actually prevented from acting against the organism's own cells. And this was always thought as being the definition of autoimmunity, but this is actually, he talks about autotoxins. which are really the inflammatory cytokines being overproduced. So my interpretation is that he was actually thinking about autoinflammation and hyperinflammation as well. What are we talking about? We all know what autoimmunity is loss of tolerance with the recognition of epitopes of self-antigens, and you need specific antigen receptors to do that. Autoinflammation is slightly different. Autoinflammatory diseases are those diseases that are essentially secondary to activation of innate immune response in the absence of triggers or in the presence of a trivial trigger. Think about cold exposure for cold-induced urticaria, for example. This leads to chronic or recurrent systemic inflammation and tissue damage. We are talking, actually today, we're talking about hyperinflammation, which is an excessive and disproportionate response of the innate and adaptive immunity in response to a reasonable stimulus to do so, viral infection. You discussed a lot dengue yesterday as an infection. This response becomes excessive and therefore kills or leads to damage to the host. And we certainly use autoinflammation and hyperinflammation as umbrella terms that comprises a number of groups of disease, not even a group of diseases, groups of disease. And we have learned, certainly as rheumatologists, as I am, that autoinflammation can drift to hyperinflammation, and we know that this is dangerous. This is a typical case. This is a child with active sJIA, typical presentation. If you look at his laboratory features, he has leukocytosis, thrombocytosis, increased acute phase reactant, including fibrinogen, no signs of intravascular coagulation of the coagulation, no organ damage. A little bit of ferritin, but this is pretty usual in autoinflammation, in these forms of autoinflammation. Is standardly treated with glucocorticoids and IL-1 inhibition. However, 2 years later, comes with a different pictures. He has persistent fever, severe splenomegaly, and the general picture is very severe. And we have learned to see this array of laboratory abnormalities: low white blood cells count, thrombocytopenia, low fibrinogen with signs of intravascular activation of the coagulation, increased tissue damage. This is liver tissue damage here, and ferritin. And we all love ferritin. Now this is, apologies, I forgot to turn on my phone. So this is one of the flavors that we are used to, okay? And it's an easy flavors because we know the patient, we know he's at risk of hyperinflammation, and we can recognize easily the pattern. But this comes into different flavors and unfortunately with different names. We use hyperinflammation, cytokine release syndromes, cytokine storm syndromes, HLH, MAS, hyperferritinic sepsis with multiple organ failure, multisystem inflammatory disease in the context of COVID infections, on top of everything else. And it gets really complicated to try to understand and to identify these syndromes with one name, which we don't. So I like to thank, and I'll do it again in the end, a number of people that were convened together with Scott Canna to try to identify early points to consider at the earliest stage of the diagnosis of something that we decided to call HLH-MAS. And this is a picture of us and the last time we met in person, which was actually August 2019. And one thing these groups decided was that we didn't want to go into nomenclature. Nomenclature is too complicated. We keep calling these things with different names. We understand these things as different flavors. And in the end, we came up with the decision of calling, for the purpose of this effort and for the manuscript that is going to be finished pretty soon, HLH-MAS. We don't want to claim that this is going to be the name. We just decided to use it for this effort. I'm going to use it in my talk. So there is a recognizable pattern, which we have already partly seen. And I like to point out or do here. So the pattern comprises fever, splenomegaly, inappropriately low hemoglobin platelet counts or white blood cells, and this may include neutrophil and or lymphocytes. There is organ dysfunction, typically liver, but there is increase in LDH as well. There is coagulopathy, Increased D-dimers precede low fibrinogens, very often central nervous system dysfunction, and other inflammatory markers, including ferritin. So the do here is that this pattern cannot be evaluated one by one. These parameters have to be evaluated collectively and longitudinally. None of this is specific of anything, as you well know. Ferritin is a key feature. Yes, high ferritin is a key feature. And essentially, all patients with HLH-MAS have elevated ferritin. All available criteria for hyperinflammatory syndromes, HLH-MAS, whatever you want to call it, include elevated ferritin. But there are different thresholds in different sets of criteria, and ferritin is used in different ways. So this is a very old paper. It's almost 15 years old. It's actually 15 years old. It's consecutive patients admitted to the Texas Children's Hospital in Houston with ferritin values greater than 500. And it's a few hundreds of patients. You know, ferritin above 10,000 was very sensitive and very specific for HLH. The other take-home message is that there is an increase in ferritin. Just look at disease category 1, which is HLH, and at the scale of the y-axis, there is an increase in ferritin levels during HLH disease. So again, pointing to longitudinal evaluation of ferritin. Now, 10,000 is a cutoff that worked in this set of patients. However, I remind you that this is only greater than 500, which is abnormal anyway. So the different cutoffs in this set of samples and in other set of samples leads to different sensitivity and specificity, and it's very difficult to define a cutoff. But the do that I think should be in our mind when we perform early evaluation of HLH-MAS is that we do have to measure ferritin, yes. And if we have ongoing suspicion and the patients still have normal or relatively low ferritin, measure serial ferritin, because ferritin changes over time. And this is one of the things that add support to your suspicion. Hemophagocytosis. This will be discussed later in detail, but I'll give you my take. My take is, it's not only my take, it's also the take of the group I showed to you before. So 60% of patients with MAS had hemophagocytosis at the BM aspirates, and these are data from the large 350 patient collection from Francesca Minoi and Angelo Avelli, but 40% did not. And if you look at the diversity of paper in HLH patients fulfilling the 204 criteria, up to 50% of them do not have hemophagocytosis in their first BM aspirates. So if you want to use presence of hemophagocytosis for diagnosis HLH, then you're tossing a coin. You have the same probability of, you know, getting the proper diagnosis as tossing a coin. So my take here is it's a don't. Don't wait for hemophagocytosis to make a diagnosis for HLH-MAS. Unfortunately, the first H of HLH stands for hemophagocytic lymphohistiocytosis. So the H there is really wrong. And I think we should think about this in the future because it's misleading. Now, think about the modern ultra-dotted biomarkers if they are available. Here is the list of them, and I'm not going to talk about all of them. I'm going to show you a couple of data on 3 of them, which I think will become more and more useful. So think about them if available. One is IL-18, and the story about IL-18 started when, you know, these 2 back-to-back papers appeared a few years ago in Nature Genetics, showing that essentially a disease characterized by abnormal activation of the NLRC4 inflammasome caused prominent overproduction of interleukin-18. These patients have huge amount of interleukin-18, and they have recurrent episodes of MAS-HLH. And then there is a novel disorder which is due to one specific CDC42 mutation, and this patient, guess what? They have abnormal activation of the NLRC4 inflammasome. I won't go into the mechanism. and very high level of IL-18, and they have recurrent lethal episodes of HLH-MAS. And we have progressively learned in these few years that actually IL-18 is a biomarker in sJIA, predisposing to MAS. And I'll show you what is the pathway and why I think we should use IL-18 as a biomarker. It is important, oh yes, it's important. Here is a paper of a patient with an LRC4 associated disease, the disease I showed to you before, treated with an IL-18 inhibitor, showing resolution of MAS episodes, decrease in ferritin, and possibility to taper essentially all treatment except background canakinumab. And we now have a bispecific antibody, which binds to both IL-1 and IL-18, based on a canakinumab arm and an anti-IL-18 arm, and this is going to be tested in LRC4 gain-of-function mutation to control the inflammasome-mediated overproduction of both IL-1 and particularly IL-18. Let's go back to mice. So from the future to long time ago, in the perforin deficient mice, which do develop HLH when triggered with the virus, HLH is reversed by interferon gamma neutralization and by CD8 positive cell depletion. Have we learned something regarding biomarker of HLH? I think we have. This is a paper that was published by our group, plus more additional data, showing that actually level of CXCL9 were really significant increase during MAS, but not during active sJIA, and they do reflect interferon gamma production. Here you see the data in MAS and in active sJIA, and you see there is a very tight correlation, increase of CXCL9 and a very tight correlation with ferritin levels during active MAS, but not during active systemic JIA. And this is true for CXCL9, for the correlation with the number of the typical parameters of the patterns that we have described before, including ALT, LDH, platelet count, and neutrophil count. Again, showing that CXCL9 increase reflects specific abnormalities of the pattern of hyperinflammation. And this has become even more evident when the trial with the anti-interferon gamma antibody was performed in children with primary HLH. You see here is data from 2 patients showing clearly that the decrease in ferritin was paralleled by decrease in CXCL9. Again, showing that CXCL9 reflects interferon gamma activity, and when you neutralize interferon gamma activity, you get rid of CXCL9 and your ferritin decreases, pointing to the importance of interferon gamma in this specific disease. Even more importantly, logistic regression analysis in this trial indicated that that low CXCL9 levels at the end of treatment were associated with clinical response with the highly significant p-value. I'm sorry, I duplicated the slides. So back to IL-18 and CXCL9. This is a very nice slide from a paper by Scott Canna. You'll hear him tomorrow, I think, who has measured IL-18 and CXCL9. And what you see here is a pattern. In MAS associated with sJIA, IL-18 is very high and CXCL9 is increased. In primary HLH, familiar primary HLH, you see that IL-18 is not that high, while it is high in at least part of the infection-associated HLH. So you can see a pattern here, a pattern of patients in which IL-18 is very increased here, and a pattern of patients in which IL-18 is not increased. However, CXCL9 is increased all over the board, suggesting that actually IL-18 is important because it does induce interferon gamma production. Let's switch to T cells 1 second. So although Michael Jordan discovered that CD8 positive T cells were important in HLH in 2004, he came up with the biomarker evaluation in vivo in patient only in the middle of last year, in 2021. And this is a very nice paper showing that actually activated CD8 positive T cells expressing HLA-DR and CD38 are really expanded in patients with HLH. And they are able to distinguish early HLH from early sepsis with an area under the curve of 0.92, which is almost perfect. In our laboratory, Juicy, together with Ariana in the clinics, decided to look at sJIA, MAS in sJIA, and other secondary forms of HLH. And again, you can see the same population is present in this secondary form of HLH, and the area under the curve to distinguish from active sJIA for motor inflammation, it's again almost perfect and it's almost ideal. And we also identified a new population of CD3 positive cells that express CD8, that are CD8 positive and have low level of CD4 dim CD8 positive T cells. These are very high in patients with MAS, several forms of secondary HLH, and appear to distinguish as well as. So this is very trivial flow cytometry that almost anybody can do. So I think we should think about these three biomarkers, IL-18 associated with autoinflammations and high-level predisposes to HLH-MAS. CXCL9 is associated with HLH-MAS and reflect interferon gamma overproduction, and CD8 activated T cell populations, particularly CD4 dim and the CD38 HLA-DR positive cells, appear to be useful in a clinical setting to identify patients with HLH-MAS. Now, besides the biomarker, we still use our diagnostic classification criteria. There are several sets. There are 3 sets of criteria that I'd like to point out to you. They perform well in the settings in which they were generated. They tend to identify the pattern, the recognizable pattern we have talked before, but they perform well in a given setting, the setting they were generated from. Okay, so this is sJIA-MAS, this is adults with cancer and HLH secondary to malignancy, and this is primary and secondary HLH, but mostly monogenic HLH. Let me get into one little piece of detail. And this is from the MAS criteria in sJIA, and I'm sure you know them. So platelet threshold and fibrinogen threshold are well within normal limits. So you don't have to wait for profound cytopenia or profound coagulopathy to think about MAS HLH. You just have to think that these things are inappropriately low. You would expect thrombocytosis, not borderline low platelet counts in this patient. And in the data set that was used to generate that criteria, we had a consensus meeting altogether in which we looked at change over time. And it was pretty clear that it was a change over time of these 3 things that were considered most important for the diagnosis of MAS in this context. So changes over time are important. So my take-home message here is no single set of criteria is sufficient to diagnose HLH-MAS across all contexts. Trends over time are more relevant than absolute values. And the don't is do not apply strict to the criteria. Just don't go with the criteria, snatched on the door of your ICU. Think about the trends over time and not the absolute value. The last message concerns underlying and predisposing condition. Now, this is a mess, to tell you the truth. There is a very large group of underlying or predisposing conditions that are associated with HLH-MAS, and they include a lot of stuff: infections, rheumatic diseases, malignancies, metabolic diseases, genetic error of immunity, and more than that. This is a rather old classification of HLH, but it gives you a message. The genetic forms are really rare. Well, they may get to 5%. I don't think we get to 10%. I think they're below 5%. Okay, and everything else is everything else. And you have to look for secondary HLH or acquired HLH. And this is a major issue when you are dealing with a patient with early suspicion of HLH. Let me get a little bit into a couple of examples. Let's assume you have a patient with early HLH-MAS, and you think that there is an underlying inborn error of immunity that has to do with cytotoxicity, as you know. So you have to perform cytotoxic functional test and genetics testing. You have to do, yes, you have to do it early, because identification of a monogenic HLH-MAS dramatically affects management. You have to use the better available approach, which is etoposide, which is not really used in all the other sets of HLH-MAS. The early, the better. The early, the better you start to look for a bone marrow donor, because this is the only curative treatment so far. So this is something you have to start thinking early even if it is rare, but you have to start thinking about it. I'll make the other example regarding infections. Now, the list of infections that have been associated with HLH-MAS is huge. It will need 10 slides, and you won't be able to read the slides because the font will be too small. The other take-home message here is that frequency of each infection depends on local prevalence and on genetic background of the populations. However, immediate treatment of the underlying infection may be all that is needed to stabilize the patient. You may not even have to use immunomodulatory treatment. Think about leishmania. So what I'm trying to convey here is do early evaluation for underlying predisposing condition and postpone treatment if possible until diagnostic testing for underlying condition is concluded. So, and here you are in between. It's not an easy situation most often. You have to use common sense, and there are no data to guide you here. But I think these are two good principles to be used. And finally, early stabilization and treatment I alluded to. Some of these patients are acutely sick and they worsen very rapidly. Sometimes it's a matter of not even a day, it's a matter of a few hours. They can, almost die overnight. And so there are one do and one don't. Try not to use glucocorticoids before having excluded malignancy. This is particularly important in adults. Malignancies are very rarely associated with HLH-MAS in children. Try not to use them because they will mess up with your ability to diagnose a malignancy. When you want to stabilize a patient, high-dose glucocorticoids are your best drug, okay? But they will interfere with some of your differentials. Anakinra and or IVIG won't. So I think these three should be considered. And this is as far as I will go. Can't get into more detail, also for the sake of time. I would like to thank you for your attention. I would like to thank the people that work in our group in Rome, both the clinical people, Claudia, you will meet her right after me, and the laboratory people, particularly Giusy and Valentina and Ivan, that are pivotal in running the HLH-MAS studies that I'm shown to you. I would like again to thank the group of people. This is Scott Canna, you'll meet him tomorrow, Rebecca, Angelo Ravelli, and many other people that you probably know by face. Thank you very much for the attention. I'll take any question.
Thank you, Dr. Benedetti, for a wonderful lecture on do's and don'ts in a cytokine release syndrome. There are a couple of questions in the chat box. The first question by Dr. Kausalya is, how long after the fever starts would the ferritin touch that 10,000 levels? So do we need to keep monitoring them serially because the ferritin is not high enough?
I think again is the trend. You don't need to achieve 10,000 to have a strong suspicion or even a diagnosis of HLH. It's the trend over time, and there is no time cutoff here. Some patients stay there for a while, and all of a sudden they get worse. Okay, it's the pattern, but ferritin must be part of the pattern and has to be tested longitudinally. I'm sorry, no rule here. Just clinical common sense.
This is unfortunately not that common.
Well, it's unfortunately and fortunately, if I may say so, because it's the beauty of our job.
Absolutely.
Sometimes we get dengue patients with a ferritin of 30,000, 40,000, but if they're clinically stable and the fever is settling down, other parameters are settling down, we just wait and watch. And after maybe 24, 48 hours, the ferritin will start reducing. I had one question, sir. Do you use procalcitonin level also as one of the markers for cytokine release syndrome?
I mean, in some patients, it is increased. We have seen some patients with, let's call autoinflammatory, triggered or associated HLH-MAS with high procalcitonin, but it's not generally the rule. And therefore, I think I don't think we have enough data. I don't have enough data. I don't think we have enough data.
There are a couple of other questions. Dr. Madhumati has this comment to make. If hemophagocytosis like a toss of a coin in a macrophage activation syndrome or a HLH, shouldn't we change that? Wouldn't mass be a superior term to use? I think you would agree as a rheumatologist, isn't it?
No, I wouldn't. It's forbidden. Don't talk about nomenclature here. No, but I think again, common sense. Don't wait for the first age to appear.
Correct.
That's wrong. We don't need it. We'll discuss it. But I think my easy take-home message is that we don't need it. It's confirmatory. Yes. The reason why you do your bone marrow aspirates as soon as possible is because you want to exclude malignancy. This is one of the ways to exclude malignancy. So yes, you do it, but you don't look for hemophagocytosis. Look for something else. If you find it, you get nice pictures.
Sir, how about monitoring anti-inflammatory cytokines like IL-10?
Those are all difficult questions. No, I don't think you should. I think it's increased. It's going to be increased, market increased, because the system is trying to pump up the anti-inflammatory pathways as much as it can, because the system understands that there is too much inflammation. So sepsis is very high level of IL-10.
Yes.
Is it helpful? Is it good or bad? Talking about diagnosis, I think it's not useful.
Okay.
There is one interesting question. Should we consider screening children with sJIA mass for familial HLH? If not for all, but at least for a few, and who would be those whom you would screen for HLH?
For familiar HLH?
In the systemic onset GIA, whom would you screen? Would you screen anybody for a familial HLH, like perforin, monk, or associated genes, or you wouldn't?
Why don't you ask this question to Claudia Bracaglia? This is what she's going to talk about, and she has the data more at hand than me. But I would not. I would not. But I'll tell you a very brief anecdote. We had a patient presenting with fever, rash, tenosynovitis of the wrist, polyarticular involvement, high fever, rash, splenomegaly, MAS. So this is sJIA with MAS. Well, now it turned out that the patient was lymphopenic, a little bit too much, and lymphopenia persisted. When it got better, it was pretty clear that he was very young, he had less than 1 year. It's pretty clear something was wrong with his CNS. And it turned out that he had PNP, purine nucleotide deficiency, phosphorylase deficiency, which is actually associated with an immune defect, and it's an inborn error of metabolism. So do we screen them all? No, well, we pay attention for things that do not fit the pattern of sJIA and MAS.
Okay. Particularly if the age is less than 2 years, consanguineous marriage.
Sorry, I missed, there was a breakage in the connection.
Is if the age is less than 2 years of age or consanguineous marriage, then you will think more.
Yeah, this is one of the things that is out of context. Yes.
Dr. Fabrizio, thank you very much for answering.
My pleasure.
And there are 2 questions in the chat box. Whenever you have time, if you can just kindly answer. For the want of time,